Welcome everyone to tonight's webinar on monkeypox update for primary care. My name's Kathy Tepper and I'm very pleased to welcome you all here on behalf of Eastern Melbourne PHN and Northwest Melbourne PHN. I'd like to start by acknowledging the traditional owners of the land on which our work takes place, the Wurundjeri Woi-wurrung people, the Boon-wurrung people and the Wathaurong people. We pay our respects to elders past, present and emerging, as well as pay respects to any Aboriginal and Torres Strait Islander people in the session with us tonight. Just some housekeeping. All attendees are on mute. Please ask questions via the Q&A box, not the chat box. Questions will be anonymous to protect your privacy. The session is being recorded. And please ensure that you join the session using the name that you registered with. This is very important for sending out CPD points and certificates. The way that you change your name is by clicking on the participants button at the top of your Zoom window, hover your mouse over your name of the participants list, and on the right side of the Zoom window, you should be able to click on rename and enter the name you registered with. Very pleased tonight to welcome three speakers. Aaron Osborne is an epidemiologist from Northeastern Public Health Unit. Dr. Melanie Bissessel is a sexual health physician from Melbourne Sexual Health Centre, and Dr. Charles Alprin is a director of Western Public Health Unit. Now, our agenda for tonight is that we're going to have an epidemiological update, first of all from Aaron. Melanie will speak next on the clinical care of monkeypox, and Charles will finish on the role of the PHU in monkeypox and beyond. We'll then have time for questions at the end, and hopefully we'll have lots of questions and our three panellists will be able to stay online and answer those questions. Thanks. Aaron, over to you.
Thanks, Kathy. Thanks, everyone. I'd like to start off by acknowledging the traditional custodians of the land on which I'm on, which is the Boonwurrung people of the Kulin Nation, and also the traditional custodians of the land on which Nephew works, which is the Wurundjeri people of the Kulin Nation, and pay my respects to any elders past, present and emerging. I'm Aaron Osborne. I'm epidemiologist at the Northeastern Public Health Unit, and today I'm just going to run through a little bit of a situation update around monkeypox. A bit of a background on what we're going to talk about in this session is I'm just going to do a little intro to sort of the history of monkeypox and some of what we know about transmission, and then spend a fair chunk of the time talking about the global situation update. I think there's lots we can learn about what's happening in other jurisdictions that happened already that will inform sort of what's happening here. Things are still early and emerging here within Victoria, so I think having an understanding what's happening in places like Europe, UK, US will really help us understand what we can and can't expect from monkeypox over the next little while. So a lot of you may know or be aware of this already, but monkeypox is a pox virus similar to smallpox. Conventionally is zoonotic. It's transmitted to humans through animals, but obviously things are a little bit different in this context. First identified in 1970, an endemic in Central and West Africa. Traditional monkeypox outbreaks in West Africa are sort of even between males and females, and really more common in children. And these are really important to take note because this is actually really different to what we've seen all of this year. I won't go into some of the clinical presentations because I know we've got a whole lot of time to talk about some of that. So this is from the CDNA guidelines. The main transmission is through contact with an infectious animal or human, and that's through broken skin or mucous membranes, materials contaminated with the virus, respiratory droplets, and it's still unclear whether it can be transmitted through semen or vaginal fluids. This is from CDNA guidelines. I'll present some of what we're seeing globally, and I think that while these are some of the ways it can be transmitted, this isn't what we're really seeing. So we'll sort of unpack a little bit about what actually is transmission looking like globally. Incubation period 5 to 21 days, and cases are considered infectious from the onset of symptoms until the rash has resolved, and they aren't considered infectious prior to the onset of symptoms. So globally, since the start of the year, there's been about 50,000 cases of monkeypox, and sort of 99% of those have been in areas that haven't seen monkeypox before. So this graph here, the orange dots represent identified cases of monkeypox in places where they haven't seen monkeypox before, and these blue dots are where historically they have seen monkeypox. There obviously are things are a little bit different to what we've historically seen with this. This epi curve here is broken down by regions, and it really shows two things. The red here is the European region, and the blue is the Americas. And what we're sort of seeing is it was driven early in the US, this outbreak, and then towards the US, and we're sort of on the lagging end of that. The other thing I think to note here is the deaths are really low. So we've seen 50,000 cases, really only 15 deaths. In Europe, there's been about 21,000 cases, and overwhelmingly these cases are in males, 99%, and a really high proportion are HIV positive, and a lot of these cases report male-to-male sexual contact. It's looking like in Europe that the epidemic is declining, and they're on the other side of increasing cases. Specifically, when we look at the UK, the trend continues. We've seen, of the 3,000 cases, 99% men. They're also seeing a decline in cases, and they really haven't seen any evidence of airborne transmission. And within that, they've actually seen really limited household transmission. It really looks like this is the epidemic driven by sexual contact. So, and that's really evidenced by when we look at some of the enhanced surveillance. So this is a subset of those cases where they looked at specific risk factors. And there's 97% gay, bisexual, or men who have sex with men, and had really a lot of markers for high sexual contact. Its history of STIs in the last year was about over 50%, and a really high proportion having multiple sexual partners in the last 3 months. And interestingly, here, this is looking at those same things we talked about now. Sorry, it might be a little bit blurry. And those proportions haven't changed throughout their epidemic. So even though they've had an increase in cases, and now that's starting to decline, the demographic profile of the cases hasn't changed. So it's remained concentrated within this cohort, and that's highly sexually active gay and bisexual men who have sex with men. And that, I think, supports a lot of what we're seeing, is that this is a disease that's spread from high levels of skin-to-skin contact, and so is primarily being transmitted probably through sexual contact. The US is yet again the same story. 99% assigned male at birth, and over 99% reporting male-to-male sexual contact. I think they're a little bit later in terms of when this happened, so haven't quite seen a decline yet. And it's worth noting that in that context, it looks like it's significantly impacting certain cultural groups that conventionally experience disadvantage. So when we look at Australia, we've only had 106 cases as at 25th of August, and we've only very recently, in the last few weeks, had evidence of local transmission. And there's only 2 states that have had evidence of local transmission. That's New South Wales and Victoria, and I think the numbers in New South Wales are quite low. And so currently within Victoria, there have been 61 cases of monkeypox and about 30 locally acquired cases. And it's at this stage, we're seeing a really similar profile to what we've seen globally, and it's 100% male cases, and overwhelmingly confirmed male-to-male sexual contact and have had report indications of high sexual contact. So I guess the question is, based on that, is Victoria and Australia on the same trajectory that we've seen in the US and the UK? We are seeing an increasing number of locally acquired cases. It does suggest that there is local transmission, and overwhelmingly, we are seeing it impact the gay, bisexual, men who have sex with men community, especially in those who have high levels of sexual activity. So that suggests that we are going to see something similar to what's happened in Europe and the US. But I think that there are signs that this might be different. I think there are seasonal differences. They were in summer at the peak of their epidemics, and when this started to be seeded was in prime sort of Northern Hemisphere Pride events in June, July that would have acted as super spread events. We don't have those same events. There might be behavioural differences in terms of these sorts of events here in the middle of winter that would act as seeding events here. And I'm optimistic that there might be some early adoption of behaviour change. There's US data that's saying, reporting that gay, bisexual men who have sex with men are reporting reductions in their number of sexual partners, one-time sexual encounters, and use of dating apps in response to monkeypox. So there's an opportunity here that potentially with early messaging that this might reduce some of the transmission. And we have the rollout of the vaccine in September. So I think it's a little bit of a tricky balancing act at the moment about whether that behaviour change will hold out until we can have a meaningful rollout of the vaccine into this community. So the key take homes from this is there is increased local transmission of monkeypox in Victoria, and it's primarily in sexually active gay, bisexual, and men who have sex with men. Although I said at the start from the CDNA guidelines that there are a whole number of ways that this can be transmitted, it actually looks like it's really only being transmitted through sexual contact where there's high levels of skin-to-skin contact. Globally, there's no evidence of airborne transmission at this stage, and really limited numbers of household transmission. I think with the numbers that we're seeing in Europe, we'd expect to see a whole lot more cases in, especially like in females, if there was going to be transmission outside of skin-to-skin contact. The access to vaccines will be critical in September to making sure we keep on top of this moving forward. And I just want to say that obviously the situation is evolving. So what I say now might be very different to what I say in 2 weeks' time. This is an emerging threat. We don't know whether we will see similar patterns as to what we've seen elsewhere, and we'll be actively monitoring what happens. And that's all from me. I think there's a little Q&A at the end, so please feel free to post any questions, and I'll happy to address them at the end. Thank you.
Thanks, Aaron. We're going to go to Melanie now.
Thank you. Can everyone see my slides? Lovely, thank you. Thank you, Aaron and Kathy, for acknowledgement of country. And I also want to say that some of my slides overlap with Aaron, so I'll just skim or skip some of those slides so we don't have the same information repeated. So basically, Aaron spoke about, about monkeypox spreading mainly through intimate contact, including oral sex, anal sex, and vaginal sex, or even touching the genitals of a person with monkeypox. So hugging, massage, and close contact through kissing or prolonged face-to-face contact is also a source of spread of monkeypox. Touching fabrics and objects during sex, like sex toys or bedding, may also be a source of infection. And importantly, a pregnant person can spread the virus to their fetus through the placenta. We're still investigating as to whether there's some direct spread to anyone through close personal, often skin-to-skin contact, like through infected objects and fabrics or even surfaces. Also looking at contact with infected respiratory secretions, but we know that contact with the rash or the scabs or even bodily fluids can spread from person to person. So basically, while monkeypox at present is mainly in the gay and bisexual and men who have sex with men community, we know that this is a public health problem and can affect everyone. I was hoping that in this presentation, I could present some data that was presented at the International AIDS Society conference in Montreal, because there was a special dedicated session on monkeypox, which was actually put on very quickly to spread important information about monkeypox. So the individuals from the WHO presented some information, and Aaron also had some of these in their slides. But we could see that the number of monkeypox cases at the time of the conference, as at 22nd of July, which is the time of the conference, that there were 75 member states across 6 WHO regions who had been experiencing monkeypox cases. And by then, there were 16,000 cases at the time of presentation, including 5 deaths. And then again, as Aaron presented, they were mainly men who have sex with men. There were 114 female individuals affected. There were 253 healthcare workers, but within the healthcare workers...
Attention all staff, Met Call 3 East, Cardiology. Attention all staff, Met Call 3 East, Cardiology.
Sorry, I'm just at the hospital, so please bear with
Attention all staff, respond Grey Emergency Department, cubicle area. Attention all staff, respond Grey Emergency Department, cubicle area.
Hopefully we won't get many of these announcements. So basically there were 253 healthcare workers that were also affected, but within this cohort were men who had sex with men. So this denominator is not completely reliable, but the majority of cases were individuals with known mode of sexual transmission, and commonly the exposure was parties, bars, and large gatherings. The median age, as one can see here, is between 30 and 39 years of age. And when they looked at the monkeypox transmission and the exposure type, the majority was sexual encounter, and the majority were during going to a sex party or large gatherings. But there were also others where there were some fewer cases, though, contact with contaminated material or some person-to-person contact. So overwhelmingly, it is sexual contact that's the main source of infection. And some of the clinical features of that presentation was that individuals presented with an early vesicle. And so you could either think that this is a pimple, even molluscum contagiosum, or a little sebaceous cyst that is erupted. But as time goes by, the lesion becomes larger and more ulcerated, and then eventually, as it matures, forms a scab, and then eventually re-epithelialization occurs once the scab comes off. But the concern was that some individuals presented with systemic signs and symptoms, and then also presented with severe proctitis or even urethritis, and some with urinary retention. Some individuals needed to be hospitalized for severe pain, and there were a few cases in ICU with encephalitis. So this graph here indicates what the common presentations were, but we could see that systemic signs and symptoms were characteristic of the infection as well. Then there was a really good presentation by a person from Chelsea and Westminster, where they looked at specifically looked at monkeypox cases, and they broke them down according to, they looked at 101 cases, but at that time there were 624 confirmed monkeypox cases. The majority, again, were in the gay and bisexual community. The majority were Caucasian. The individuals that had HIV had an undetectable viral load, so they had a good CD4 count, so their immune system was really good. And the majority had reported a new sex partner, so it's new and casual sex partners rather than regular sexual partners. And some of them had actually traveled outside of the UK. So they looked at these 101 cases, and they found that 66% of these patients had fever, prodromal symptoms. Some of them had asthenia, generalized fatigue and muscle ache. 32% had headache. Some of them had a sore throat. But interestingly, 17% did not report any prodromal symptoms. The mean incubation period was about 9 days, and the majority had a mild illness with symptoms lasting a few days. And when prodromal symptoms were reported, 64% of them, 2/3 of them, had the rash and the lesions at the same time as the prodrome. But in the 1/3 of individuals, skin lesions occurred after the prodromal symptoms. And the median in time from prodromal symptoms to actually reporting lesions was about 2 to 4 days. Then you have the eruptive phase, right? And the 99% presented with at least one characteristic skin lesion, which I'll show you some pictures of next. But they could either be macular, so just a stain on the skin, or they could have been pustular and vesicular, which resembles chickenpox and herpes simplex, or they could have crusted lesions like the crusted lesions of chickenpox. Some of them was ulcerated, some were severely ulcerated. It depends on the type of sexual activity the individuals were engaging in. So the lesions actually mirrored sexual activity. So if the patient had anal sex, they had anogenital lesions. If they had oral sex, and the lesions were in the oral cavity. Some of them had generalized presentations as well in the trunk and the limbs. Some of them had lesions on the face, 20% on the hands and the feet. So you could see it could actually represent, confused with other dermatoses, including syphilis, okay? Interestingly, 62% of them had inguinal lymphadenopathy, which was often bilateral. And the skin lesions occurred at different stages of evolution. So whilst one lesion may be crusting, a new vesicle might be developing in another spot. 1/3 of patients had lesions on 3 different anatomical sites, so the anus, the genitals, the face, the throat. And they had a wide array of skin and mucosal presentations. But the direct inoculation, the type of sexual practice, was associated with the lesion distribution. But worryingly, 17% of patients, about 20% of patients presented with proctitis, so severe anorectal pain, deep-seated anal pain. So these patients constipated themselves. They couldn't go to the toilet to pass a stool. Some of them had urinary retention. They were scared to go to the toilet to pass urine. Some of them, because of cellulitis and abscess formation and bacterial superinfection, needed antibiotic treatment. Those who had oral lesions had large lesions in the oral pharynx, and if it involved near the tonsil area, they had difficulties with swallowing and severe odynophagia. Some patients, although it was not common at that time, had corneal involvement and needed an ophthalmology review, and those patients automatically get antiviral treatment. So it could be a great mimicker like syphilis as well. So we have to have a high index of suspicion. Therefore, whenever anyone sees an ulcer or a lesion, especially in the anogenital area, it needs to be swabbed for HSV PCR, herpes simplex PCR, and TP PCR, which is syphilis PCR. So this, whenever you see anogenital lesions, always cover for HSV PCR, TP PCR, and now monkeypox PCR. At the same time, this occurs due to intimate sexual contact. So sexual health screening is also very important to look for other STIs like Neisseria gonorrhea, chlamydia trachomatis, or even syphilis infection. So it's really important to test for other STIs, including those commonly occurring infections, as well as HIV and other bloodborne viruses. So these are some of the common presentations. So you might have a solitary penile lesion, or one here on the scrotum, one on the thigh. This typically looks like molluscum. So you could easily get confused that this is molluscum. So whilst you may actually be tempted to perform cryotherapy on these lesions, it's best not to do that. Rather swab for monkeypox. And if it's monkeypox negative, then you could use cryotherapy on lesions that you would like to spray. These are some examples of the lesions that the UK cohort had. So here, this is a lesion on the face. So on day 11, the lesion was PCR positive for monkeypox. And then by day 21, where there was crusting, the lesion became PCR negative. Then let's look at this lesion on the genitals. You could see there's a large ulcer there. And then by day 21, the ulcer became much larger. It had a very erythematous base with a clear demarcation. But by day 28, it was PCR negative. Now, you don't have to PCR these lesions at days 7 and 14 and 28. The most important time for PCR to do a PCR test is at the time of presentation. Okay. Let's look at this lesion here, which is just above the eyebrow. So there's the eyebrow here. On day 11, it was just a singleton small lesion. The patient could have confused it with a pimple. And by day 21, the lesion had become very, very large. And these are some oral and perioral lesions, which are really very, really, they can make the patient feel very uncomfortable, and they can cause scarring, and it doesn't look very nice. So there's an individual with lesions on his lips, extending into the upper lip and into the chin. You could see that there are ulcerative lesions. Some of them are punctate lesions. Here, this person has it on his nose. This person has lesions on the corner, so you think this is herpes simplex. You'd swab for herpes simplex virus and monkeypox. This person has a lesion on his tongue. This is on the undersurface of the tongue. And these are on the oral pharynx. So you can imagine this would definitely cause odynophagia. Patients would have severe difficulty swallowing. Let's look at some perianal and rectal lesions. So here you could see some lesions here. Here lesions have actually coalesced. So there's a large lesion. Several lesions have come together. Here you would think that they look like flat warts, but here you could see they're umbilicated and ulcerated. Here at the anal rectum, the patient has got a singleton lesion and a smaller one that's evolving. And here, this patient has severe proctitis with very painful defecation, and eventually the lesions coalesced. So it's important to do an HSV PCR, TP PCR, that means treponema pallidum PCR, because this could look like condyloma lata of secondary syphilis, or it could be monkeypox. This is a lesion on individual's penis. You could see multiple ulcers, PCR positive on day 5. Then the ulcers are becoming much larger and spreading. And here by day 13, they're becoming smaller and scabbing off. Here in anogenital lesions, it's when they start coalescing to form a large lesion that patients have difficulty going to the toilet to pass a stool. Here on the coronal sulcus, the patient had lesions, then eventually coalesced to form almost necrotic type lesions, okay, with this necrotic type material coming through. So as Aaron said, as of the 25th of August, the website showed that there were 106 cases. So, it's not spreading at a rate of knots like it did in Europe, the UK, and the US. And I think that's testimony to the fact that we have actually been very good with our public health messages. We've been able to get the vaccine. We tried to mitigate this infection, right? And so we procured some vaccines and tried to get the vaccine into the arms of high-risk individuals. So at present, as Aaron mentioned, there have been about 50,000 cases globally, but in Australia, there have been 106 cases, with the majority in Victoria and New South Wales. In New South Wales, they're mainly coming from individuals who've traveled overseas, but there may be some circulating virus that's where patients have actually not presented to their doctor for or to the sexual health clinic or GP for testing and management. Therefore, it's very important to get a public health message across without stigma, to encourage individuals to go and see their health practitioner to get tested so that they can isolate and prevent spreading the infection in the community. In terms of Melbourne sexual health, where I work, there were 31 cases as of the 25th of January, similar distribution to the UK cases, similar distribution to the cases that Aaron presented. The majority of them were on PrEP, so high-risk men engaging in high-risk sexual encounters. The median age was 39. Some of them had overseas travel, but not all of them. And the majority went to several different continents over different countries over many continents. Again, our median was about 4 days of symptoms before the presentation. We suspected 16 on face value, on just looking at them clinically, we said that this was actually monkeypox, but some of them took us by surprise because we did test for monkeypox thinking that this was herpes or syphilis, but actually was an atypical presentation and was actually diagnosed as monkeypox, okay? And some of these patients had paraphimosis, they couldn't retract their foreskin. 7 of these patients had proctitis and some of them had cellulitis. We had to send patients to the Alfred Hospital for hospitalization. Not all of them received antiviral, some of them just received fluids and antibiotics. And some patients consented to photographs being taken, so you can look at our STI atlas for more pictures on monkeypox. But again, it was really important to do other sexual health screenings, including HIV and other bloodborne viruses, because syphilis, chlamydia, gonorrhea can all coexist in patients with monkeypox infection. So these are our daily cases over the period from the time we started screening to the 22nd of August. This is work from Janet Towns, who's doing lots of work on monkeypox, Melbourne sexual health. And there's our weekly cases as well. And the majority of our cases were detected in August. So our common locations were in the genital area, in the anorectal area, and on the face. Similar sort of presentation to the pictures I showed you, on the tongue, over the mons pubis area. Some patients had them on their limbs. But this patient had a severe proctitis that needed to be admitted to hospital because he had severe pain and he couldn't pass a stool. This person here thought that he had a herpes infection. This patient had a necrotic type lesion on his face and was very distressing for him. This patient had severe odynophagia, and this person had a paraphimosis. So any lesion, swab for herpes simplex PCR, TP PCR, and now monkeypox PCR. Okay. So the special considerations when you sampling these lesions, and you need to sample several lesions. So don't just sample one anogenital lesion. Wherever the lesions are clearly documented on the swab where the lesion is actually coming from. And usually you're wearing good PPE and you take the swab from skin or mucosal lesions. If the lesion has got a vesicle, then you can de-roof the vesicle and then swab from the base of the ulcer, okay? And we usually just use the HSV PCR swab or the TP PCR swab. So just make sure with your local pathology provider, you've actually found out what swab to use in case, and make sure that you have plenty of swabs in the practice so that you don't run out, okay? And as I said to you, make sure you do a TP PCR and HSV PCR. On the pathology request, remember to include whether you're doing surveillance. That means you don't really think that this is monkeypox, but you're just doing a surveillance, or you suspect that this is monkeypox, or this is a monkeypox contact. Now, if you're re-swabbing a person at day 7 because you want to see whether they still have a PCR positive, write down on the pathology slip that this is a known case. So this is not regarded as a new case of monkeypox, okay? So you either write monkeypox suspected, or monkeypox contact, or monkeypox surveillance, okay? If you suspect that this is a monkeypox case or the patient is a monkeypox contact, then the directive that we've received is that you triple bag the specimen, you seal it and you wipe it over with antiseptic wipes. Make sure that the test tube is actually screwed on properly, because you don't want the specimen to leak in transit, okay? And the majority of the community labs, Melbourne Pathology, Australian Clinical Labs, Jodovich, etc., they all send the specimens to the Victorian Infectious Disease Laboratory called VIDRO, where Melbourne Sexual Health and some of the high caseload GP clinics send their specimens directly. But remember, monkeypox PCR is Medicare billed, so directly Medicare billed, so no out of cost expense for the patient, okay? But make sure you got all the contact details of the patient, their mobile number, with their consent, of course, so that the public health units and yourself can actually contact the patient. And the public health units will contact the patient directly and let the patient know that they're being tested for monkeypox, that the turnaround time is about 24 to 48 hours, and that if they are monkeypox positive, they will hear from the public health unit, from yourself as well as from the public health unit too. Make sure that the patient is aware that they're being tested for monkeypox. And then if you get a positive result, this is how you will receive it in your clinic. So the result is detected. They do a real-time PCR for orthopox PCR, and then also a real-time monkeypox PCR. And then they give you information about the Department of Health contacting the patient, and then you also, as a provider, need to contact the Department of Health as well. So the lab sends the Victorian Department of Health the result, but will also send you the result. So you, as a referring medical practitioner, has to make the notification as well. For symptomatic and supportive treatment is mainly the mainstay of treatment. So these patients need some paracetamol, they need some fluids, they need, especially in the prodromic phase, you can use non-steroidal anti-inflammatories as well, and lots of fluids. But when they have lots of complications, it's a problem. So you might have to use stronger painkillers if they've got severe proctitis or urethritis. Now, the problem with opioids is, you know, that themselves can cause constipation. So you've got to be very careful with this. You might need to use some topical lidocaine gels or even proctothelial suppositories to help with constipation. Antibiotics also are important if there's bacterial superinfection or abscess formation. They might need to be sent to hospital for surgical incision and drainage of abscesses. We have seen some severe cases of cellulitis, especially over lymph nodes and the skin. And they may need to be catheterized if they're unable to pass urine due to urethral pain. I want to talk a little bit about the antivirals. The antivirals are not easily available, and they usually need to be signed out by the chief health officer of the hospital to be used. So they're really reserved for severe cases, so patients requiring hospitalization and where simple supportive measures or antibiotics have not been helpful, okay? It's not really a treatment approved by, but it's for emergency use treatment, and mainly for severe cases, young children and pregnant women because of the risk of spreading to the fetus, okay? And most of the studies on these antivirals are mainly in vitro or on animal studies. The one that's been used in Australia is tecovirimat. It's a viral envelope protein inhibitor. So what it does is it stops the replication of the virus. And we know that in animal studies, it's effective in treating disease by this orthopox group for which monkeypox belongs. And what it does, like valacyclovir for herpes, shortens the duration of illness and reduces replication, reduces viral shedding. There have been some other antivirals being used in other countries like cidofovir or brincidofovir. These are DNA polymerase inhibitors, and we know again that they're effective against orthopox viruses. And brincidofovir particularly was used in the US for the treatment of human smallpox. But the best is to consider post-exposure immunization. So if somebody says there's close contact of someone with monkeypox, within the first 4 days to prevent transmission, get the patient to get vaccinated. And many of the sexual health clinics and the high caseload GP clinics have vaccine set aside for post-exposure immunization in the first 4 days, okay? And it's best to give it in the first 4 days. And while the patient is contagious, they must avoid contact with others. Lesions and exposed areas must be covered. They must wear a mask and perform good hand hygiene. For those close contacts, they need to monitor for symptoms for 21 days, to get vaccinated in the first 4 days, and of course, to seek medical help if they develop lesions, because they need diagnosis and testing and treatment as well. And basically, once somebody has been put into isolation, so in Victoria, the local PHU advised cases of monkeypox of the isolation requirements. So we know that a person with monkeypox is infectious from the onset of any symptoms, including prodromal, until all the scabs and exposed sites have fallen off and you see intact skin. So patients can leave isolation when their symptoms such as their fever, swollen lymph nodes have resolved. And number two is where they have no new lesions for at least 48 hours. There are no mucous membrane lesions. All lesions in exposed areas have crusted. The scabs have fallen off and there's re-epithelialization. So you see really good skin coming through. In those in the anogenital region, as long as it's covered, as long as they've crusted over, even if it's not fully healed, they can come out of isolation, but the lesions need to be covered at all times when in contact with other people. And individuals with monkeypox should be advised to avoid sex for 8 weeks after the recovery because of persistence of this monkeypox virus in semen. And that's still a moving target, still evolving. Then you need to send an email to cdir@health.vic.gov.au to inform the patient, to inform the Department of Health that you've cleared your patient and he can leave isolation. So this is an example. Dear Department of Health, my patient has been reviewed today, and you give the date. He has no new lesions in the last 48 hours. He has no systemic signs and symptoms, or he's never been systemically unwell. The genital lesions have crusted over. He has no lesion in exposed areas at all. And then this email serves to confirm that he's clinically cleared of his recent monkeypox infection. And the email address is up. And then, of course, make notes in his clinical file as well. In terms of vaccinations, 2 vaccines have been approved for use in Australia. That's Jynneos and ACAM 2000. The Jynneos vaccine, as we know, is the modified vaccinia, Ankara strain vaccine, so MVA and BN, right? So Bavarian Nordic, that contains a virus that has been altered, so it cannot multiply in the human body. Okay, so it's really important to explain to the patient that it cannot multiply in the human body. It's not it's not like the ACAM 2000, which can. It's given as 2 doses, at least 28 days apart for people over 18, but we can actually have a clear discussion with patients if they're worrying about it being a problem in children, and especially in high-risk groups, in patients 16 years and over. You have to discuss the risks and benefits. Now, we know that it's not currently registered in Australia because at the moment it's available under an exemption for emergency use only. So it ensures that the vaccines are available urgently to deal with this public health threat. Okay, but Jynneos is known by different names in other countries, is registered with both the FDA and the EMA. In terms of ACAM 2000, it's a live attenuated smallpox vaccine that is also effective against monkeypox. Okay, and it needs a lot of training and lots of training of the vaccinator because it's given as a 2-pronged vaccine. Okay, so because it's a live vaccine and has replicative capacity, it's not suitable for the severely immunocompromised, pregnant women who are breastfeeding, those who have cardiac risk factors, people who have got active eczema, replicating skin, and infants below 12 months of age. So it is registered with the TGA for the use in Australia, but it's hardly used because we have the Jynneos vaccine. And with Jynneos, there's some pictures here of how it's actually given, but basically you draw up, the vaccinator will swirl the vial and draw up from the vial, and then give with a very tiny needle, a subcut 25 gauge needle. And there's been a little bit of discussion about using intradermal Jynneos instead of subcut, because you'd get more out of one vial, because you use 0.1 mil of the vaccine for intradermal use. So that will probably be the next route of transmission, next route of administration, but training is required for vaccinators to give intradermal Jynneos vaccine. And the usual reactions may occur, like injection site reaction is the biggest thing, with a bit of redness and a bit of itching and swelling, but it's self-limiting and it's probably gone in about 2 to 3 weeks at the most. Okay, so the best time for people to receive the vaccine is before they're exposed to monkeypox. The person is exposed to monkeypox, receiving a vaccine within 4 days after the first exposure will provide the highest chance of avoiding the disease. So first 4 days of monkeypox contact. Vaccination between 4 to 14 days will likely just lessen the severity of the disease, but won't prevent it. So we say once we procure more vaccines and more vaccine is available, if we know someone is going to a high-risk country, Europe, UK, and the US, they need to get vaccinated before they depart to allow for maximum protection. But we know that vaccine supply is limited, but we're getting more and more vaccines, so more and more vaccines will be given into those who are at greatest need. So at the moment, we prioritize in groups, so the close physical contacts of confirmed cases, and those who are at higher risk of exposure or further transmission. So basically, gay and bisexual men who have a high number of sexual contacts. So to mitigate their risk, we're saying to individuals to actually reduce the number of partners that they have in this time period until they're fully vaccinated, to reduce the number of casual partners, okay? And individuals who are at risk, who are with other comorbidities, who are more likely to result in serious illness, they need to be prioritized for vaccination. And then, of course, people whose occupations might put them at increased risk, like laboratory staff and healthcare workers such as ourselves. We know that the monkeypox vaccine works, it's very effective, but you need 2 doses, okay? So if you just here, they've broken it down to HIV positive and HIV negative, but I think the difference is minimal, okay? So 7 to 14 days after the first dose, you get about a 30% protection. And this goes up to about 60%, 28 days after the first shot. But the second dose is the one that gives you the greatest, confers the greatest immunity, and that's usually 14 days after the second shot, where you get close to 96 to 98%, okay? So really the second vaccine is really, really important, but the first one does confer some degree immunity, okay? So we continue, as Aaron says, we continue to monitor for emerging evidence. Is it spread through respiratory secretions? Is it spread through surfaces? Do we detect the monkeypox viral DNA in saliva, semen, and nasopharyngeal and feces? When someone has got an asymptomatic infection, can they actually spread it? Is the prodromal period the presumed infectious period? So this is a moving target, and it's evolving, and we could get more and more information as we get to know more and more about the infection. I want to ask you to please look at this website, Health Pathways, that many of the general practitioners are familiar with. Health Pathways is written by GP clinical editors with support from local GPs, from hospital-based specialists, and other subject matter experts. And they've actually got a very good pathway for monkeypox as well. And you can register for Health Pathways, or you can use the Health Pathways username and password supplied by your local PHN. But as I said, this is an evolving infection. So the pathway is currently being drafted, but there's a lot of information similar to what I presented about monkeypox, about assessing the risk for monkeypox, how to actually diagnose the condition both clinically and through the laboratory, and what you have to do to notify the Department of Health, etc. Okay, and there's also important information on management, vaccination, and preventative advice. Okay, so and these are also important resources that are available on the internet. So I look forward to some Q&A later. Thank you. I'll just stop sharing.
And Charles, over to you.
Thank you. I have to admit, I just deleted a couple of slides as I'm going, so I don't want to be repeating stuff. I also want to start by acknowledging traditional owners of the lands who are all on today from the various public health units and across our catchments, and paying respects to elders past, present, and emerging. So my slides should start to appear there. I'm adding another website to your list to check out, the WEFI website, on which we do have some guidance for clinicians aimed for both general practitioners and also emergency department clinicians, saying much of the stuff that we've said today, that we have a communicable disease spread by close direct contact, that the message is test, that the message is advice will change, and that we're vaccinating. We think it's worth understanding recommendations around PPE and also what your patients can expect if they are either in contact with somebody who's infected with monkeypox, or if they themselves have infection. So we really do need with monkeypox a careful, sensitive, nuanced approach to control. We have three groups of people who we're talking about. We have those who are infected, who need obviously the clinical care that that Melanie has already detailed, for what can be really a distressing condition that 9% of cases in the data are presented hospitalized, commonly causing hospitalization, often for pain management. It's an unpleasant condition, and people need to know how to stop spreading it to others and what they can do to help themselves. Then we've got those who may have had that being close to somebody who was infected when they didn't know they were infected, but could have been infectious. And for them, we're giving advice on what they can do to know immediately if they're unlucky enough to become unwell and to get tested, whether, as Melanie pointed out, they're eligible for vaccination that could reduce the likelihood or the severity of illness should it happen, and how they can make sure that if they are unlucky enough to develop disease, they can not spread it to anybody else before they find out about it. And then we've got the community at large, for which the approach is messaging to understand what to look out for, to understand how they may choose to what choices they may decide to make to limit their exposure to monkeypox, or if they are exposed, to limit the likelihood they would develop illness or become unwell from it. Now, you'll notice in that I chose my words really quite carefully. I tried really hard not to say words that we've all become so accustomed to over the last couple of years in terms of COVID control. It may be my bias, I admit that, as somebody in communicable disease control in Victoria over the last couple of years, everything is cases, contacts, cases, contacts. This is not a COVID approach. We are dealing with cases and contacts and vaccination and community engagement, but I think it is so important, and it goes to some of the comments that I've already seen in the Q&A, that we are very careful to avoid any stigmatization and to acknowledge what Melanie was saying about how this is transmitted and how it is not transmitted, and therefore what we as public health practitioners can advise and recommend. But I can assure you, and personally I would appreciate if patients could also be assured that, whereas with COVID, public health for the first time kind of started telling people what to do and putting laws down, that is not an approach for monkeypox. The approach for monkeypox is recommendations and advice. And as we've seen in Europe, that's the approach that works. So should one of your patients become a case, I'll use the word, then the public health unit will contact them. We will make all possible efforts to ensure that you have contacted them first. So we will be contacting your practices to make sure you're aware. Sometimes results can come through to us quickly from Vigil and take a little bit longer to get to practices. So make sure you're aware, and we're very conscious that clinicians are in charge of the clinical care of their patients. You have the relationships with your patients. You are the person who has told them they're being tested. And it's definitely a preferable experience for them to hear of the diagnosis from their clinician rather than from somebody calling from a public health unit. That said, we will contact them. And for cases, now I've put the Better Health Channel advice at the top there because that's what we're linking to and where the advice is staying up to date. For cases, we're giving advice to try and limit the potential for transmission within their household. We are saying try to stay at home. We're saying stay at home in a separate bedroom. If possible, use your own bathroom. Use designated household items and do your own cleaning if at all possible. And if you're in common areas of your house, consider using a mask. Avoid others. If we really do strongly advise very limited leave from the home. So certainly if you want to go out and exercise, why would that be a problem? To go for a run, and of course for medical reasons. But if you're ever with others, use a mask. Abstain from sexual activity, and it's on the list, so I'm going to talk about it because of the zoonotic potential of monkeypox and the fact that it can move both from its reservoirs in the animal kingdom to humans and back. At present, we are saying that you should avoid close contact with any pets such as rodents, rats, mice, hamsters, gerbils. Avoid contact with them, and that advice might evolve over the coming days and weeks. So we do suggest that you just check in with advice before telling your patients what they could expect. For contacts, the clock starts ticking at the last date of exposure and ends 21 days after exposure. And for contacts, we're really saying messages that aim to stop them transmitting disease should they develop it but not know. So that means if it's possible to work from home and therefore avoid crowds on the tram or avoid unexpected public areas, that would be great if you wouldn't mind. Furthermore, if you could avoid high-risk settings such as aged care facilities and healthcare facilities, that would be great. That said, for people who work in high-risk settings, it is perfectly possible for that to happen. We would consult and recommend use of PPE. We may, with their permission, talk to infection control in their institution, but this is not a situation where we are banning things. We do ask that people avoid crowds and non-essential outings and avoid contact with people at high risk, which quite frankly, people want to do. Nobody wants to be spreading this. Avoiding close contact and sexual activity and other interventions that you could probably predict. We're also saying if you have any symptoms, get tested and call the medical facility ahead of time because they will want to ensure that you're wearing a mask when you come in and that there's no potential for direct contact or for large droplet spread as there would which could happen for monkeypox. It's been mentioned already, and I'm not going to go into it in too much detail other than to say vaccination is coming. Currently, at Melbourne Sexual Health Centre and other high caseload clinics, generally towards the centre of Melbourne, vaccination is happening, and there are thousands more doses coming in a few weeks' time. I'm not going to be any more specific than saying in a few weeks' time. We're confident that by the end of September, we'll have broader outreach and many more vaccinations. There's the possibility, as Melanie mentioned, of intradermal use, which would increase the number of doses. But some complexity and training to be worked through before that's in place, and then there'll be many more doses in the new year. Post-exposure prophylaxis for high-risk contacts identified within 4 days of exposure, and the public health units, when we find contacts within 4 days of exposure, are very happy and able to link those people in with the high caseload clinics or with hospitals where there are also a few doses being kept, a few doses of vaccine being kept for PEP. So look, as with all outbreak control, you'd have seen it over the last couple of years. I can give you many examples over many years and many continents of it all boiling down to community. All outbreak control is about how people react to your messages and how people engage with the potential for reducing transmission. It's been a lesson learned by many in COVID or before. Western Public Health Unit, Northeastern Public Health Unit, where Aaron is, and by the way, there's another Metropolitan Public Health Unit called Southeastern Public Health Unit. We're working very closely both with our regional colleagues and with the Department of Health and many community stakeholders, including Melbourne Sexual Health Clinic, Thorn Harbour Health, and others. It's going to be really important, especially for something like monkeypox, that the messaging is careful and respectful, avoids stigma, is consistent across the state, and that we acknowledge that it's going to evolve and it's going to change. Already, as Aaron has alluded to, we're learning more things about monkeypox. We're seeing many more cases than we'd ever seen before this outbreak that just started a couple of months ago. And so we're going to find out more things. And as we find out more things, our advice will change. I think that was something that we were very explicit about in COVID and actually handled pretty well. And I don't think, and I think it's reasonable to stress it in. Quickly, a quick word about local public health units, which you may or may not be aware of. There are 9 of them. 3 of them are in the metropolitan regions, that's Wefu, Nefu, and Sefu, with the other 6 in the regions. Set up initially for COVID, we now have an expanding scope into both health protection and population health and health promotion. I'm not going to go into it in too much detail, although our website is there, and I'm very happy to be contacted through that website if anybody has any questions or would like to engage further in any of our other work. Now, this slide you have seen before, but I'm coming back to it because I really think that it is the key. Control of communicable disease, as with any non-communicable disease as well, is all about community. It's all about linking people with messaging, explaining the steps they can take to protect themselves and to protect others, acknowledging that as we learn more, things will evolve. Wefu has a website to which you can go for up-to-date information directed at clinicians, and the Better Health channel is there as well. I'm not going to look at Aaron's face because he will probably be wanting me to talk about the Nefu website, which is fair enough. We've all got them up and running, and we are keen to engage carefully with our communities, with clinicians who work locally, and with all our stakeholders to make sure that we can deliver really careful, place-based, targeted and tailored, but consistent public health response. I'll stop there and let us go to the Q&A. Thanks.
Thank you very much, Melanie, Charles and Aaron, for your informative presentations tonight. We've had quite a few questions coming through your presentation, so I'm going to start at the top. Is there concern around stigmatisation of the GB-MSM community, given the high rates of infection and transmission within this group? We'd like to answer that.
I think Charles touched on a lot of that already. I think there definitely is, and I think a key part of this response is engaging with community leaders and the community to be the real drivers of those messages, to be the drivers of this response, and I think that'll be critical moving forward. And the other thing I want to flag, and the key message coming from mine, is I think being really clear and transparent as much as we can be with the information we have around what the risks are around transmission. And I think being allaying fears that you don't have to worry around your office colleague who's gay that you're going to get monkeypox off them. That is not a concern that you're going to have, and not to worry about community members and things like that. So I think being really clear about what our understanding of transmission is and what the actual risks to community are, because they are truly quite low.
Charles, did you want to add to that?
Yeah, I just wanted to add to that the other aspect that is worth reassuring on is around transmission in practices. Monkeypox is transmitted through direct skin-to-skin, intimate contact. It's transmitted through large droplets. I would not worry if I was standing next to somebody with monkeypox. If I was taking a throat swab from somebody with monkeypox who could unpredictably cough, I would probably want to make sure that I was wearing a mask and a face shield, because they might cough, but not because they'd be breathing at me. So this is the messaging that I think is worth saying. You know, it's not easy to catch. It is direct, intimate contact. That's the pattern across the world that has been seen epidemiologically and is consistent with what we've known about the disease from previously.
Okay, thank you. Next question. Do most pathology labs process monkeypox swabs?
I can take that one if you want. No.
Thank you.
So Vidril are the only lab currently processing processing the swabs, but they are looking to roll it out to other labs. I would say though that Vidril have capacity for more testing. There's very much a message coming from Vidril that they can take on more tests. Test. If monkeypox crosses your mind about a lesion, test. There is testing capacity out there. What happens for the swab that you take is it goes to whichever primary lab you use, and they send it on to Vidril. Vidril then process it. If the result is positive, they'll send the result to the Department of Health, and they'll send the result back to the primary lab, who will send it to you. So there can be a couple of hours in that getting from Vidril to primary lab to you versus Vidril to us, which means which is why we're so careful about reaching out to clinicians to make sure you're aware that your patients have a diagnosis.
Thank you. Is there much scarring when lesions heal?
I'll take that one if that's okay. Look, I think it's really important to reassure individuals that usually scarring is rare unless they interfered with. So it's like a pimple on your face. If you pop the pimple and you squeeze it, you are going to get some scarring. So usually, if you leave the lesions and you allow them to just scab off naturally and reepithelialization occurs, scarring is not common.
Thank you. Someone's asked about the protocol for testing for monkeypox now, which I think you've gone through fairly well, but they've also commented that it was recommended to contact the local PHU for advice for testing monkeypox a few months ago. Does anyone want to add to that?
I might take that. I think that has changed now because we're trying to encourage doctors and clinicians to actually test for monkeypox. They've removed that hurdle. And you can just test, as Charles has said.
Yes, thank you. Someone's asked about the criteria for antivirals, which I think you've also since gone through. Did you want to add anything to that?
I think with antivirals, usually the patient is hospitalized and the chief health officer of that hospital will say that it's okay for tecovirimat to be used, but it's not easily available. It's not going to be available at community pharmacies or even at sexual health clinics as yet.
Thank you. Is there a cost for those without Medicare?
For testing, no, it's processed by the state.
Right, thank you. Someone's asked if they can have a PDF of Melanie's presentation. I think we were planning to send out the recording of tonight's session to everybody. We've also got updates on health pathways, and I think we probably will send out a list of resources as well. Another question, for those who had received smallpox vaccines in the past, like overseas students, do these people who engage in high-risk behaviours need a booster?
What a great question. Melanie, do you want to hazard a guess?
Yes. Well, look, in my reading, I know that unless you've had the smallpox vaccination in the last 3 to 5 years, it's unlikely to confer immunity. So, no, you should get the monkeypox vaccination if you belong to the high-risk group.
Okay, and that answers another question too. Can people who have had previous smallpox vaccination be vaccinated with the monkeypox vaccine? So yes. Okay, another topic. A colleague had his vaccine done 2 days ago, but it was done in the left forearm where we would normally do MAN2 or Q fever skin test. Is this appropriate?
I can take that one too. Look, I think that the diagram that I actually showed was to give it in the back of the forearm, but there are quite a number of vaccinators who are giving it in those areas that you just described. So I don't think it's a problem at all. And I don't think it will cause interference with any other tests.
Okay, great. Okay, another question. What likelihood of scarring is there from the vaccination?
Well, we'll know in time, but basically, usually the lump develops about 3 to 5 days after the vaccination. It can become a bit itchy and last for about 1 to 2 weeks, but the majority just resolve as you would with any vaccine.
Okay. Is a monkeypox the same type of swab as herpes or syphilis, dry swab? And do we need to call up for special permission before taking any swabs?
Okay, so I think we answered that earlier that you don't need to get permission, but it is the same at Melbourne Sexual Health and in high caseload GPs. It is the same swab that we use for herpes simplex virus and treponema pallidum PCR for syphilis. But as I said, that you need to just contact your local pathology lab to make sure that you're using the right swabs. But having said that, if the swabs are all going to Vidro, then using an HSV PCR swab is fine to actually send to Vidro.
Okay, thank you. Next person has commented on a great presentation, and thank you. Another query, what advice would you give to the travellers travelling to high-risk areas?
So one of the indications currently for vaccine is people intending to travel to high-risk areas before the end of October who are gay, bisexual, or other men who have sex with men. And so if intending to, especially if intending to engage in, to have sex overseas in high-risk areas, get vaccinated. And to be aware of what the situation is in those high-risk areas and decide on your risk appetite and whether or not you want to you're going to engage in activities. I think that's the key, the knowledge and the counselling as to what's going on, how you can protect yourself, how monkeypox is transmitted. Yeah, Melanie, if you've got anything you wanted to add on that.
I think you've covered that well, Charles. I just also want to say is to limit the number of partners and it's the new casual sex partners that are the greatest risk. So they should, partners that you know, partners that you've been with before, regular sexual partners are all encouraged.
Yeah, it's a really tricky area to message around as well, because we don't want to be saying to people, and this goes for within Victoria, limit sexual partners, don't have sex. That's not messaging that's gonna, that's stigmatizing. It's not appropriate. But some really clever messaging, some really careful, respectful messaging that's we've seen from overseas, exactly as Melanie just said, has been around the consider limiting to known sexual partners, consider sexual bubbles, those kinds of things. So the messages that we've seen from overseas, perhaps not relevant for people who are going overseas, which is where this question came from, but it does go to how does one message around the concept of limiting sexual partners, which needs to be done respectfully and carefully, but is a conversation worth having.
Do you diagnose on a throat swab or swab of lesion?
So we swab the lesion, and so if there's a lesion in the throat, then you swab that lesion in the throat, but you still actually do a general STI screen of the oropharynx and the anorectum if those are sites of sexual activity.
Thank you. Is asymptomatic testing warranted for close contacts?
Sorry, please give me the question again.
Sorry, is
Staff respond grade.
asymptomatic testing warranted for those close contacts?
Attentional staff.
Well, at Melbourne Sexual
grade.
Health, we actually...
East unit, cardiothoracic.
Sorry about that. At Melbourne Sexual Health, we are actually testing asymptomatic contacts, but this is just a study of asymptomatic contacts of the throat, the rectum, and the urine, but it's not generally done out of a research setting, no.
I'd add to that our current advice is that you're infectious when you're symptomatic, and that I wouldn't recommend swabbing asymptomatic contacts, because when would you not swab them? So I would recommend advising contacts that should they feel unwell, they should have a low threshold for getting tested. Certainly if they had any lesions, they should be tested. If they feel unwell and get tested and they're negative and then develop lesions, you would want to test again. But testing people who have no symptoms, I would not recommend.
Okay, the next question is actually a comment, so I'm just going to read it out. It says it's important to remember that a relatively large portion of the GBMSM community are not connected to the traditional LGBTIQ community networks. Also, MSM can be non-identifying, closeted, or living in heterosexual relationships. They may not be reached by LGBTIQ media, and the risk of being outed may be a barrier to accessing care and vaccination.
We're very conscious of that. I completely agree with that. We are, without speaking too soon, there are efforts that are going on to extend the availability of monkeypox vaccine into clinics that are not the high caseload clinics, and so improving access to vaccination, and vaccination being performed in a way that does not out you and identify you and is respectful of privacy. That you can opt in or out of a vaccination being reported to the Australian Immunisation Register. And so, yes, we're very conscious of that and completely agree. And also going to some efforts to engage, to have engagement efforts that will connect with those communities and those people.
Thank you. We've got a couple of questions here about swabbing. The first one is, you said using HSV swab types for testing monkeypox. Is there a need for its own separate swab for this purpose, or can you test HSV and monkeypox from the same sample?
You can test HSV, TP-PCR, and monkeypox from the same sample. The community labs are actually sending the entire sample to Vidro for those 3 tests. In time, the community labs may actually do their own HSV PCR testing and TP-PCR testing, and then just require another swab for monkeypox testing to be sent to Vidro. But at this stage, you can use the same swab for all 3 organisms.
Great. And that answers the next question. When taking swabs for PCR, do we need to take 3 separate swabs for monkeypox, HSV and TP? But it can be done in the one. Okay, next one. For the handful of positive symptomatic cases who knowingly choose to disregard advice to reduce spread, are there any public health enforcement laws?
There are laws, but it would be a very big deal to use them. We all know there are laws. We've seen them in use over the last few years, but if there were people who, there are procedures for other conditions as well, of people who we know to be putting others at risk. And we have very specialist teams able to engage with those individuals. Where we know about them, those teams would engage with them. But for a condition such as monkeypox, it would be an extremely big deal to use law to enforce anything.
Thank you. You mentioned vaccination being recommended for healthcare workers who may be exposed to monkeypox patients. Healthcare workers are not on the current list of eligible groups issued by Vic Department of Health. Are we able to access vaccination? Who's able to answer that?
That one. Now I'm searching for, so healthcare workers and laboratory workers. Aaron, do you have the vaccination indications right in front of you right now? I haven't got the exact words right in front of me, but I'm looking for them.
Well, I can just answer that while you're looking for a chart. But basically, the healthcare workers who are in direct contact with the fluids, like the laboratory workers or those taking swabs and stuff like that, but we don't have enough vaccine at the moment. So the high risk categories are prioritized. But eventually, I think healthcare workers, when we procure the next lot, will probably be considered as well.
Thank you. There's a comment here, flagging Thorn Harbour Health have commenced vaccination for priority populations that is being given via intradermal route. There is an interim Department of Health guideline referencing intradermal administration, and people eligible for vaccination can register via the Thorn Harbour website.
Yeah. And may I also just put in the plug for Thorn Harbour? They've been really good. They've gone into saunas, sex on premises venues. They're vaccinating over the weekends at Pronto, Equinox, at all their centres. So they're working really hard to vaccinate the high-risk population group. So a big shout out to them.
I was coming off mute to say exactly the same, and they've got fantastic community-focused materials on their website. Big shout out to Thorn Harbour.
Okay, wonderful. So that's thornharbour.org. Another question, what is the risk of reinfecting with monkeypox post-infection? And does monkeypox infection give you lifetime protection?
Well, that's one of the evolving questions. We actually don't know the true answer to that. We'd assume that when you are infected with monkeypox, you have a degree of immunity. So we're saying to those patients who've just been recently infected that they shouldn't, that there's no need for them to get vaccinated at the moment. So we're thinking that the individual is probably immune for about up to 3 months, but we actually don't know for sure.
Okay. How far back does contact tracing go? 3 months, someone's asked.
Well, the incubation period is about 2 weeks. So we probably would go back a month to 6 weeks. I'm not sure if you have anything to add there, Charles.
Yeah, look, we're seeing pretty consistent incubation periods. And in fact, on your slides, where you had the timeline slides that you showed with some lesions, you had incubation periods of 5 or so days. We're seeing pretty consistent incubation periods of 5 to 7 days, to be honest. Like people who said, oh yes, I had an encounter 7 days ago, or I was at a sex on premises venue 7 days ago, and then 7 days later I started feeling unwell, or I got a spot. So we looked 21 days prior to symptom onset, because the incubation period is up to 21 days, but the incubation period is commonly 5 to 7 days. And often we're finding with the cases, even if they don't know precisely who the person that they were in contact with, they can identify an episode where they had high-risk contact at precisely the right time for contracting the disease based on their symptom onset date. So we'll contact trace back to look for how they might have acquired, and then we'll contact trace forward to work out who's a contact and who we're then going to therefore reach out to and say, hey, you need to be careful, you need to get tested from symptom onset date.
Thank you. Someone's asked a question again about smallpox vaccination. Does multiple vaccinations of smallpox protect against monkeypox?
I don't really know the answer to that. I think that, we've got the Jynneos vaccine here, so and that is has been approved for emergency use. So I think we should be using that vaccine, which we know is safe and can be used on most members of the public with no difficulty.
Thank you. Can you please comment on the management of pregnant health workers who come into contact with monkeypox?
Charles, do you want to take that one?
Look, specifically of pregnant health workers, no, I don't know. I could comment specifically on that. However, I will comment that our experience thus far of healthcare workers coming into contact with people with monkeypox is that maybe because of COVID, but whatever, PPE use has been such that we really haven't been worried about the contact. Monkeypox is transmitted through close, direct skin-to-skin and intimate contact or large respiratory droplets. So the use of PPE that is very commonly used in many clinical settings at the moment is protective.
Okay, thank you. Now I've got quite a long question here. I recently tried to test for monkeypox on a child. I understand it wasn't the right demographic, but there was some symptoms. But after doing the swab, was contacted by the local ID team and advised not to test due to the demographic not being correct. I was also advised that in future I needed to send the patient to the hospital to do this or get permission from DHHS before swabbing. I work in a Geelong GP clinic. Is this correct?
Not anymore. I'm not sure when that advice was, but you're entitled to swab. If you think monkeypox, we're happy for you to swab.
Right, thank you. Someone's mentioned about a target advice if vaccinated more than 10 years ago to revaccinate.
Okay.
Yeah. Okay. And we've come to the end of our questions. So thank you everybody for all those questions you submitted. Also like to thank Melanie, Charles and Aaron for all the work you put in and for the presentations and for your time tonight. That was very informative. We would like to ask everybody who's attending to do a survey. Now you can either, I think it was in the chat, the actual link, or if you've got your phone handy, you can just use that QR code to go directly to the survey. So I'll just leave that on the screen for a minute. Thank you everybody for your attendance tonight. We appreciate your time. Have a good night.
Thanks all.